Yeah, so there's all kinds of new health tests, whether it's the like what do you recommend when, kind of like how should we be looking at those types of things and when to start looking at them?
Yeah, so the question there is really like, to what degree do we need all this medical testing? Because you can get so much data, and routinely I'm coming into a case in my practice where there's years of results for us to review, and rarely, if ever, has the testing that I like to do been done. Why the functional integrated medicine community doesn't do more testing the way I do it, I can't really tell you. But specifically, the biggest mistake people are making is they're jumping to the things that are downstream of the fundamentals. So, for example, if somebody comes in and they say, look, I want to check my hormone panel, Dr. Stillman, I think I have a hormonal imbalance. The first thing I'm asking them is, what is your daily routine? Where do you live? How do you sleep? How do you breathe? How do you move? All these other factors that are going to influence their hormones, right? Because I know that if I check their hormones up front, there may be lots of abnormalities and problems. But if we address the fundamental mistakes they're making in their lifestyle, which are often very hidden, like I've had people come in who couldn't sleep because they were next to a smart meter. All I get them to do is swap bedrooms in the house to the guest bedroom, and 2 weeks later, their brain fog, their poor sleep, their food intolerances are going away, right? So we could have spent money on the hormone panel up front, and if we did, we'd see abnormalities, but we fix all this stuff, we recheck the hormone panel, it looks normal. So I have to gauge that based on the case, right? So somebody who comes in who's sort of typical for this crowd, I don't have to read you the riot act about getting sun, like you've got enough of a tan, right? And I don't have to read you the riot act about getting AM light and afternoon light and blocking blue light at night and that kind of thing. So I sort of make sure that the things are really good. And then if you've got good fundamentals, and honestly, a lot of what I do now is it's sort of driven by my curiosity, because when I'm curious about what the lab level is, that means that there's real options for us to treat it. Whenever you're in the conventional world, there's the way you approach lab testing, and they've got this right, is you have to ask the question, how is this going to change what we do for this patient? For example, if you get a low magnesium level, right, what are you going to do about it? Well, you're going to replete the magnesium with some protocol. You could do a combination of IV, oral, but then you'll get cases in where they don't respond. And you have to say, well, why didn't they respond? Are they wasting it for some reason? Do they have excess stress? Are they not absorbing it? So you have to go all over the place with these different things to kind of get the case buttoned up and sorted out and figure out what's going wrong. So the mistakes people are making is they're not testing the fundamentals. So what's fundamental? Everything that makes you, the food you eat, which is composed of the minerals in the food, the polyphenols, antioxidants in the food, the carbohydrate content, fatty acid content, B vitamin content, all of that we can measure, or we can measure surrogate markers of that. And what a surrogate marker is, it's a marker that changes based upon certain things in the diet. So lipid peroxides is a great example of this. Lipid peroxides are rancid fats. They'll go up the more oxidative stress there is in the system, but they're particularly sensitive to sources of oxidative stress that affect fats. So if somebody comes in, and this doesn't happen a lot in my practice for reasons that should be obvious, but they got a high lipid peroxides level, one of the things I'll ask them is, do they eat a lot of fried food? Because that's, those fried oils are full of lipid peroxides, right? It can go up from a lot of things. You can kind of look at the lipid peroxide level funny and it will go up. But those are the things I start with first. What you're going to change based on that is what the patient's eating and then how they're preparing it. Because that preparation piece is more important than people realize. And when you get into the food sensitivity world, people will really start to flesh this out. You'll find that there's people who can tolerate something called consommé, but they can't tolerate bone broth. These are different broths made with different cuts of animal flesh. One the bones, the other the flesh, right? Different amino acid profiles. So those fundamental things are key. But the other thing that people will do, even when they get those fundamentals, is they won't think through the keys to consistency, right? So if you go out, and this is why I really have to, and those of you who got NutriVals and see the reports, there's questions in there sometimes. Because if you, for example, in my last NutriVal, this is what happened. I got a call from the Collier County epidemiologist saying, hello, Mr. Stillman, this is Collier County epidemiologist. We need you to call us immediately. Okay, whatever. And I give him a call, and he's like, yes, your mercury level is 13. Are you having any symptoms of mercury toxicity? And I'm like, no, I just had mahi the night before my NutriVal, and I forgot that I shouldn't do that. So anyway, you have to be able to understand, like, is this a person who just ate mahi and has a mercury level of 13? Or is this a person who has a mercury level of 13 and never eats fish? Now, you can cross-reference that in the NutriVal with the omega-3 level. So if you have a mercury level of 13 and omega-3 level of 4 or 5, I will call you and be like, listen, what's going on? How did this happen? Did you have a massive mercury exposure? Because you're pushing it out. So anyway, back to your original question. The fundamentals are key. You can test them lots of different ways, but you have to test them with somebody who understands how to really interpret them because of the amount of context that goes into really understanding what the numbers mean. And that's something that's been kind of shocking to me, how many people come to me from functional medicine docs who've done all this lab testing, and I'll ask them, what was done about this or that or the other abnormality? And they'll say, I don't really know. And I'm like, what? Like, you don't know? So, beyond the fundamentals, hormones, key. They tell you about how your HPA axis and other hormonal axes are functioning. Getting the full panels is worth it. You can do shorter panels, smaller panels if you're just monitoring something that you already sort of have a grasp on. But again, looking at those before you get to fundamentals is I don't know if I want to say mistake or waste of time, but I don't do it. I get an anti-aging or I call it the comprehensive wellness panel in my practice. And I get more serious about that as people get older and older or as their abnormalities pile up. And what's on that is inflammatory markers, particularly things like a high sensitivity CRP. I'm looking at things like IGF-1. These are very conventional anti-aging labs. Anyone who's gone through A4M training, IFM training, should be doing this kind of workup. If you're going in and you say, look, I want to optimize my vitality and reduce or limit my aging as much as possible. And I'm happy to share what panel I run with people. If they're curious, I can get that to Amelia and Joe. So that panel is a big deal because you're looking at markers for inflammation. You're looking at hormones, all of which are critical for longevity, obviously. Beyond that, I use panels like GI testing. If there's a lot of pathology going on in the GI tract, frequently you don't actually need that. You can just do empirically work on that. And then what are some other examples of labs you're thinking about? Oh yeah, the cancer markers are interesting. And I just no, somebody just sent me this and they said you should offer this. And so there's markers for different diseases that people are constantly researching because of course there's a huge advantage to catching things early. I don't have to explain that one. And so they're trying to come up with more and more markers that are specific to certain types of cancer, like ovarian cancer. The antigen that it produces that can become elevated is called CA125. So I just ordered this for a woman who's got a very strong family history of ovarian cancer, and who recently had a diagnosis of a colon cancer polyp that was found on colonoscopy. And so those are things that you have to understand and go back to that question. How is this going to change management? So if I get a high CA125 on her, okay, great. We get her in for a bilateral ovarian ultrasound. The ultrasound will pick up the cancer, right? Let's say you had a cancer marker for something like lung cancer, and they're not really doing lung cancer blood markers as far as I know because they're currently going towards a low dose CT model for that. But let's say you had a blood marker, right? And you test the blood marker. Well, then you might go to a CT. You have to remember every single time you get an abnormal level, right? Something has to be done about it. Or the clinician at least has to have a conversation about doing something about it. I'll come back to that. So let's say you get the low dose CT. Great. Why is it important that it's a low dose CT for screening for lung cancer? Because the more CTs you get, the higher your risk of developing a cancer from the radiation. That's why there's a lot of controversy around mammography, because mammograms expose your breasts to radiation. That radiation accumulates and can set you up for breast cancer. That's why in the natural and integrative world, a lot of people are doing thermography. The oncologist, the only integrative oncologist I know of is Jim Roach in Lexington. Well, he's actually in Richmond, Kentucky. And Jim doesn't have women go do ultrasounds. Sorry, he doesn't have them go do mammograms. He doesn't do thermography. He says, look, bilateral breast ultrasounds. I don't know if it's once or twice a year. Bringing it back to the CT scans and that kind of idea, right? Let's go like prostate cancer, right? Everybody here probably knows somebody who's had or died with prostate cancer. And I say died with because what's really interesting about prostate cancer is it's a slow growing, indolent cancer that men will often end up with complications of that are painful, unpleasant. But it's also something that the treatment for is sometimes worse than the disease. Men are, may be impotent. They may have erectile dysfunction. They may have terrible pain on urination. There's pain and dysfunction that go along with it. And when you list off the consequences of, prostate cancer surgery, many men would say, I would rather go out with my boots on. I pray this never happens to me. Just like, give me some morphine. Let me have my equipment work for the last days of my life. And, I'm checking out. I have a friend he's got a history of ulcerative colitis, and he's always like, Leland, if they ever are trying to give me make me poop into a bag by removing my colon, I'm just going to check out. I'm not interested in that. So why do I come back to that? There's a lot of people don't think through what's going to happen with the treatment for their disease. And sadly, the system is set up to massively incentivize overtreatment. And so I look at prostate cancer as a great example of this because it would be great to catch it early and at least know what your options are. It's why I'll check a PSA in men. And a lot of docs are doing less and less of that. And they're doing less and less and less of the digital rectal exam, which we're all grateful for, because it just doesn't detect enough cancers. And when you do the numbers, the amount of lives saved for the amount of time, energy, money, let alone misery that goes into prostate cancer screening and then prostate cancer treatment, it's kind of a wash. And it really depends upon the values of the man. You'll have some patients who are like, keep me alive for as long as possible. I don't care if I'm just a heartbeat on a mechanical ventilator. I don't want to die. And then you'll have other men, like I said before, who want minimally invasive approaches. I don't know how my colleagues sleep at night not having 30 minutes to an hour to unpack some of these things. I don't know how I would do it. I want to be able to explain what are the treatment options. What does that mean? What should you ask your doctor when you go see them, the oncologist? Because a lot of the time they don't give patients data. What is the percent of men who are impotent after this procedure? What are the percent of, and one of the things that they don't do a good enough job of, I think, is asking people who've gone through it, are you happy you had this procedure, or do you wish that you'd gone with a more conservative approach that's palliating symptoms rather than treating the illness? So that's why I don't spend less than 30 minutes with a patient at a time. And when we do these markers, we're thinking through, well, what would we do based upon this?
Who would like to ask the next question?
So just in general, you were talking about hormones, and I'm just curious what your, what your take is on, kind of HRT as, kind of men get older, even if you're kind of healthy and everything looks normal, kind of optimizing for better than normal. I'm just curious to kind of just get generally your kind of thoughts around that.
I'll give you the straight up answer. 34. I intend to go on TRT when my levels start to dip. That's testosterone replacement therapy, by the way. Method, mode of delivery, all that depend upon what I'm seeing in my clinical picture at that point. Not married when I am. If she were to ask me, I would say, look, I think you'd be crazy not to do bioidentical hormones. Because the question really behind this question that prompts it is that, hormones are really powerful. And so if you put the wrong hormones into the system, you can make something like a cancer more aggressive and grow and metastasize, right? If it's sensitive to that hormone. The problem is the literature on hormones and their contribution to cancer is fraught with an enormous amount of confounding variables and a lot of bad science and even worse interpretation. And so I recently asked my friend Brad Weeks, he's got to be 30 years older than me, and he's been doing bioidentical hormones. He trained with Jonathan Wright of the Tacoma Clinic in Seattle. Jonathan Wright, for those of you who don't know, is like one of the first MDs in the United States to do functional medicine. He's one of the fathers really of natural and integrative medicine, and particularly bioidentical hormones. Him and John Lee are probably the two who popularized it the most and did it the most in their clinics. And I said, Brad, do you think there's any truth to the links between cancer and hormones? And he said, absolutely not. And this is where the cancer literature, you'll get really misled if you don't keep your eye on the ball. And what's the ball? The ball is all-cause mortality. People will say, oh, this drops your risk of heart attack by 20%. Well, what if it increases your risk of death? Right? That's more important. And so when you look at the hormones in that way, what you see in the hormone data is that the more healthy and vital your hormone levels are, generally speaking, the longer you live. Now, there's some caveats to that. I just read Russell Ryder's book on melatonin. For those of you who don't know, Russell Ryder did like if there's a king of the literature on the molecule melatonin, it's Russell. And he wrote it in like 1995, so it's old. It's an old book, but he wrote about this experiment, let's call it, that was done in U.S. Insane asylums when we had them. The male inmates were very aggressive, or more aggressive than the female patients, and they decided to do an experiment where they would castrate some of the male patients. This was a time before modern medical ethics, right? So they castrated a number of these men. And not only did the men live longer than the uncastrated men, they lived longer than the women, which is, just blows my mind, right? Now, no one's replicated this study. No one's checked for confounding variables, and like, if this was a paper being published today, the bottom line would be like, more studies are needed. We need more data, give us more funding. So at the end of the day, right, none of the men here are going to call me after this and be like, I'd really like a referral from you to a urologist to castrate me, right? So you have to keep your eye on the ball, which is your all-cause mortality and then your quality of life. And this is something that I get into with men because sometimes their idea about what their goals are conflicting, right? If you tell me you want to be the world's longest living man, have the fastest marathon time, and set, a powerlifting record, I'm going to tell you to rethink that. It's not possible. And that's why a lot of bodybuilders drop dead early. That's why a lot of, like find me a centenarian ultramarathoner. Find me one. You'll find these like centenarians in the Hasidic Jewish community in New York who are just like doddering around into their very, very, very old age. They're not like hitting the gym, They're not like, oh man, set my PR this morning. So, does that answer your question? Yeah. But it's really important for people to understand about hormones is that most docs doing hormones today are either not checking big enough panels or they're not checking those fundamentals. So I'll get men in who have terrible copper deficiencies because they've been eating a high zinc diet for a long period of time and they're fatigued, and you get their TRT and their testosterone's like 1300, right? That's super physiologic. And they're like, why don't I feel better? And people will just like, just like, they'll step on the gas pedal when the wheels are spinning. And they'll say, well, maybe we need more testosterone. I've seen more than one doc push people's thyroid hormone, testosterone hormone higher and higher and higher. As I've gone through my career, having worked for those guys, I've found more and more stuff that they didn't know about or that they knew enough about to think they knew how important it wasn't, like EMF or light or, you name it. So if you don't get those fundamentals right, the hormone therapies are not even, they can even make you feel worse. And that's why I don't jump to them unless there's an acute need or unless I have all that data and it looks good. Well, yeah. I mean, yeah. So, yeah. Yeah. So the question is, can you try hormone replacement therapy sort of to see if it fits your needs and lifestyle? I mean, the answer is yes. All these hormones are easy to go on and off. Where you run into problems is if you run super physiologic for a long time. Like my personal trainer who works in my practice with me, Jim Laird, is a power lifter. And listening to him tell stories about the power lifters is just like insane. You know, he used to load up like 5 cc's of testosterone, which is like 1,000 milligrams. The usual dose for guys is like 80 milligrams twice a week. He would load 5 cc's of that up, and he would like put it up against the door frame, and then he would like slam his body into the door frame to get all 5 cc's into his delt. And he'll tell you funny stories about like doing some anabolic called like Trent that he knows drugs I've never even heard of because they're not even legal. So of course I don't know how to use them. But he told me about using like Trent, and he's like, man, I just wanted to kill everything. I was like, oh my gosh, Jim. All right. So yeah, you've got to, you can do it for a trial period. I hate to say it, but this is being recorded. Where are we going to publish this later?
I don't know.
Let's just say there's some perverse conflicts of interest in the hormone world. Creating perpetual customers is a great business model. And you know, once you're on testosterone or hormones, I mean, you're coming back every 3 to 6 months for monitoring.
I have a question.
Yeah.
What do you think about this idea? And I'm sure there's more people who stand by this, but Paul Chek is the one who comes to mind. This idea that you're always going to be healthiest if you're living in the place that you were born. And like, what aspects of that are relevant? Is it like the water? Is it the time zone? Like what are the different elements? So
that's a really interesting question. I never actually, I've thought a little bit about this, but never quite that way. You have to understand your genes as the thing about your body that you really can't change, right? Or, you know, in general. And they're like tools, and the body pulls them out based on the situation. That's why when you look at genetic studies of people whose, you know, if grandma went through a famine, you're probably going to have SNPs or methylation patterns or whatever that help you survive a famine, right? So people were complaining, oh my gosh, I can't lose weight. Oh my gosh, I walked by a slice of cheesecake and I gained 5 pounds. Well, yeah, it's because grandma, like, you know, was 80 pounds and 5'4" in some poor godforsaken famine 3 or 4 generations ago. And so when you understand it that way, you realize, oh, and a lot of things start to make sense. Like statistically, people with darker skin tones have more dense bones. People who are white have lighter bones. They're more at risk for osteoporotic fractures, even though we tend to have higher vitamin D levels. Why? Because we're paler, so we can absorb more UV light from the sun, right? And so I've seen very, very few osteoporotic fractures in black people. Lots in whites. That's confounded by the fact that African American life expectancy is bad compared to white. But when you look at, I think it's, don't quote me on this, but because I just read it, I haven't really investigated it, but I read something like reaction times, neurological reaction times in Caucasian Americans are faster than in African American or black Americans, but the muscle movement time in blacks is faster than whites. White people are set up to survive. Think about it. Cold, dark environments. Look at the coastline of Europe. There's water everywhere. And so we're set up to survive drowning by having lighter bones. So I think about all this stuff. I can't prove any of it. I look at the behavioral differences between white people and other races. For example, white and Native Americans have something like 5-fold the risk of suicide of Black and Latino Americans. And there's some unique SNPs in the white population for neurotransmitters that most of you have heard about, right? Because they're very popular to test these things to try to understand, why do I think this way? Why do I feel this way? I wonder if some of those SNPs are there because they confer advantages for survival in certain environments. specifically cold, dark environments with an extreme change in photo period due to the latitude. Yeah. Mm-hmm. Yeah. Yeah. This actually goes back to that principle I talked about before, which is how's it going to change management? So if I tell you guys, okay, well, if I were to tell you, okay, you should live where you were born, you would say, well, how big of a deal is this? Like when you say like, I need to do this, do you mean like I need to do this? Or like, I need to do this? And that's something that it's like anything in my practice, right? Like it's frequently the case that someone's coming to me and they're like, hi, I work indoors all day. I've just gotten into the biohacking world. I know that I need AM sunlight and PM sunlight, and I'm doing ice baths and I'm sauning and I'm doing this and that and the other thing. And I'm taking this supplement, that supplement, whatever, but I'm still not well. What do I need to do? And I'm like, well, it'd be great if you could quit your job, move to a tropical island, and eat a local seasonal diet rich in fish and shellfish. I've had one patient take me up on that. He quit his job. He moved to Costa Rica. I didn't actually tell him that. He did it anyway. He was going to do it regardless of what I told him. He's still a patient too, which is fun because I get to practice in Costa Rica somehow. But anyway, so that's my answer to that. And it's also very much unknowable. And I track so much data with people that if those numbers all look good, I don't really care where you live. Because I know what your inflammatory status is, your sleep scores, your HRV, your anti-aging and longevity markers, your nutritional status. I mean, there's not anything left for me to dial in, until we come out with new tests that I haven't even thought of yet. Yeah. I don't know. So I don't have an opinion on that. Jack is hilarious. Jack Cruz, man, I tried, I doubled, triple, quadrupled down on everything that Jack taught, trying to figure out how good it was. I'm not going to say who this is, but I know somebody who at least he's told me, and I trust him. He says he's reached the lowest deuterium serum concentration ever recorded. And let me tell you, we're not talking about deuterium depleted water. I don't need it. I don't use it. I don't recommend it. Do I think it could be a bit player in cancer therapy 10, 20, 30, 40 years from now when it's affordable and it's not like more expensive than gold? Yeah. But Jack, where are we publishing this again? Jack does not actually see a lot of patients the way that I do, where he's seeing them, he's talking to them, he's following up with them for long periods of time, and he's totally unapproachable and incredibly antagonistic. And the thing I've learned about being nice to my patients is that they'll tell me what I'm doing that's not working. And that is why I've left every single mentor I have ever had. They do not have the stones to accept constructive criticism from patients. They don't end up getting the feedback of the therapeutic failure. And I can go through every case where I didn't get the results I wanted, when they didn't get the results they wanted. And I can be like, these are the things I think they should have done that they ignored me on. And maybe if they did them, we would have gotten somewhere. And I'll always be racking my brain for what I could have done differently, or what stone we left unturned, or what we need to do next to get them the result. I just texted a patient yesterday about this because I was like, I thought of something for him, and because he went through the whole thing, and like he was like, yeah, Dr. Stillman, I feel exactly the same. And I was like, kills me. But I'm excited to talk to him about this idea that I have for him. And so yeah, I don't trust Jack on that one. Now, my caveat to that is this: it goes back to like, what's your goal? If your goal is to live as long as possible, well, mortality, the sun reduces all-cause mortality, which means the more sun that you get, statistically speaking, the longer you live. So, there's an argument to be made for, if you really want to push the limits of longevity, the closer to the equator you live, the better off you are. Now, those of us who are pale, even at 34, I have sun damage from the year or two I spent in the panhandle of Florida. No sunscreen, on the beach all the time, paddleboarding, kayaking. I have this little actinic keratosis on my forearm that I've named Jack Cruz. And yeah. So, and you'll get sun damage. And if you're getting sun damage, you can only take 2 to 3 hours outside what latitude you're at. Then are you really going to get a longevity benefit from that? I don't think so. Besides which, with all the cool lights, I mean, Brian Richards was just showing me his light spectrum on that Sauna Space. It's an awesome, awesome tool. And you can get supplemental UVB light. You can get all these things. You can install them in your house. I have patients in Seattle. We just get them more light therapy.
Great, thank you. Does anyone have a question? Yes.
Yeah, that's right. I asked you to ask me that question, didn't I? Yeah. Yep. But the question is really, what is the utility of testing for pathogens like Epstein-Barr, Lyme, etc.? Why are these pathogens hard to test for? They're hard to test for because they are intracellular and they're fleeting. I can't take Epstein-Barr and grow it in a petri dish. I can take strep, staph, E. coli, enterococcus, all these things, and I can put them in a petri dish and they will grow, and I can say, this is the bug that you have, and this is the antibiotics it's susceptible to, and this is how we're going to kill it. And you can't do that with viruses, and you can't do that with intracellular pathogens. So people who come up to me and they say, oh, I was treated for chronic Lyme by so-and-so, what I really hear is, I received this diagnosis from someone who based it upon some combination of my history, exposure, laboratory data, and my response to treatment, which is a lot of different things. And so people will say, I got antibiotics and it cured my chronic Lyme. And I hear, I get antibiotics, it changed something about my microbial environment, and I felt better. And the devil in the details of the Lyme testing, for example, is that what they're doing is they're looking on a Western blot for homology or similarity between the different proteins that are on the Lyme bacteria. But those proteins are very similar to proteins on other bacteria, such as are found in anyone's gingiva. That's why if you look at the CDC criteria, they say you need at least 5 bands or more to show up on the Western blot to be considered positive for Lyme. And in the end, we're not even really testing the antigens. We're testing your antibody response. So we're just seeing if your immune system reacts to these things. It may have nothing to do with active infection, and it has to do with prior exposure. And so that cutoff is arbitrary, and it means that a certain number of people have a falsely negative Lyme test. It would imply that people who have a humoral immune problem, which is more common than some people realize, wouldn't and might have a lower likelihood of having a positive test. And when it comes to the viruses like Epstein-Barr, the titers imply that you've had an active replicating problem, or you've had active replication of Epstein-Barr in the recent past. And that's why you have a high antibody titer. That's what the titers mean. And the titers, for those of you who don't know, the stronger the immune response, the higher the titer dilution you have to get to in order to get a negative result. So the interesting thing about pathogens is, and this is the terrain theory, germ theory thing that a lot of you may have heard about in the last 2 years, because it really became it became like the battleground for COVID. Is this a problem of the pathogen, or is this a problem of people being sick and being susceptible to infectious diseases? And so with pathogens, they'll all go out of control if you screw up the environment and if you wreck somebody's lifestyle. When you take mice and you keep them awake, you don't allow them to sleep, after about 48 hours, they develop spontaneous sepsis in their blood. That means bacteria running around in their blood, and they die of sepsis. That's after 48 hours. I used to work 24 hours, like continuously in the hospital. And you'll see all these immune system changes with that. Where this literature gets really interesting to me is in the spaceflight literature, because you're sending astronauts up into this, because the real question is what about the environment really matters for optimal immunity? And I don't really like talking about boosting immunity or what reduces your immunity, because the immune system is this living, vital thing. you have a humoral immune response, you have a cell-mediated immune response, you have an innate immune response, you have an adaptive immune response. Within the humoral immune response is just one example. You have IgA, and you have IgG, and you have IgE, and you have IgM, and we have IgD, and we don't even know what IgD does. And we've known about it for like 20 or 30 years. So, think about your immune system not as a thing that you boost or depress. It's something that is going to respond more or less aggressively to different stimuli. So you really want to optimize it. You want to get it balanced so that if you're confronted with a virus, your immune system kills it. And if you're confronted with bacteria, it kills it. If you're confronted with a parasite, it kills it. And if you're confronted with an industrial toxin, it cleans it up. So I don't put my stock in the titers, because what I do is I fix the environment, I fix the lifestyle. I look at different things in the organic acids test in particular, because those are markers for immunological processes. So like quinolinic acid, there were a couple of borderline high quinolinic acid levels in this crowd. That's got some interesting implications for stealth infections. And if you get things right in the system and you treat them with the right supplements, frequently that just goes away. And you could do a bunch of other stuff, right? You could also put that person into therapeutic hyperthermia or a sauna and drive their temperature up and kill that infection and see it go down that way and have them feel better. You could do different protocols where you kill this, that, or the other thing. But this whole, a lot of integrative and natural medicine becomes and I really do think about it in terms of gardening, because when you're dealing with organisms, things that live, replicate, have their own life, or at least their own sort of animus, because viruses are not technically alive. That's another whole kettle of fish. Right? If you create the right soil conditions, a plant will die. If you create the right soil conditions, it will thrive. So you have to focus on that soil. What soil are you making for these different pathogens and things to grow and replicate and so on and so forth? There was recently a paper published by a German research group on why astronauts all have, or not all, but have a high rate of spontaneous reactivation of Epstein-Barr and cytomegalovirus. So when astronauts go into space, they have a tendency to start replicating viruses. And they don't necessarily get sick. They're not like getting medevaced off of the ISS. But you can detect these levels of viruses in these astronauts. And it's interesting because they're the healthiest, fittest, strongest, best nourished, most overanalyzed and monitored people while they're on planet Earth, and certainly in space. So why would they have viruses activate, right? And so this German research team wrote this long paper, and they talk about the humidity in the ISS, and they talk about the this and that and the other thing. And I was just like, I emailed them. And I said, listen, have you guys considered the impact of the fact that they're orbiting the Earth and they don't have a 24-hour day-night cycle? And because gravity is another one that we don't really understand why that or how that affects the immune system. And I said, how do you know that they're not being affected by the radio and microwave communications on the ISS? And the corresponding researcher replied, he said, those are really interesting ideas, and we haven't really looked into that. Yeah, hyper-sterile, that's a good way to describe it. But obviously it can't be sterile.
So we have about 5 minutes here. Alexia, yes.
I can make the answer shorter. Yes, number one. Our eyes are optimized to that. And so there's a lot of things in sunlight that are affecting the eye. Obviously, the red and infrared light, it's supposed to get to the back of the eye. Whenever somebody comes in with ocular problems, I say, okay, listen, number one, we're going to do red and infrared light therapy on the head and neck. And I want you to do it with your eyes closed. Most of the IR infrared light therapy folks will send you these glasses that they use in tanning booths with your light. That's just a bunch of cover your ass nonsense. because I've never heard of anyone going blind from looking into their red infrared light therapy box, light, whatever, even when they're pumping out like 50,000 lumens and you kind of have to take a minute when you've looked at it full in the face. Not like encouraging you guys to test the limits of that, by the way. But if you close your eyes in front of a red infrared light therapy device, you'll still see the light and you'll feel it. And so I want those frequencies getting to the back of the eyeball and the eyeball in general to trigger all the healing that's associated with them, because we've never lived in a more infrared light, red light poor environment than we do in 2022. So that's number one. Number two is obviously getting some of that throughout the day, morning, noon, afternoon. You need a certain amount of antioxidants in your diet to run all of the different photoreceptors in the eye, not to mention your circadian rhythm. So I will get the occasional person with a low vitamin A level. And those people run into problems with recurrent infections. And I suspect they have circadian problems, but no one's done that research yet, at least not in humans. And I haven't had the time to look it up in animals. So that's number one. Number two, artificial light at night is terrible for everything. So we want to be minimizing the amount of blue and green light hitting the eye after dark. Lack of movement, I think is so bad for the whole body. But to go along with that, people don't think about the fact that never before in history have we spent, 60%, let's say, of our waking hours just looking right here. This is bonkers. It used to be like running around in nature, looking over there, looking over here. You're constantly adjusting your vision. And so number 3, number 4, whatever it is, you need to schedule breaks if you're looking into a screen or looking at a book or just doing something indoors, to take time to go to a window or go outside and look off into the distance, because it relaxes all of the muscles in your eye that are forcing you to focus right here. And I think that's enough. Yeah. Mm-hmm. And I would ask, yeah. And I disagree strongly. I would ask them, can you show me a reduction in all-cause mortality to the wearing of sunglasses? And they would be like, well, no one's ever going to study that. I would be like, you are the problem with modern medical science. You have the curiosity of an invertebrate, and you think that everything is about drugs, surgeries. It's just bad thinking. So, yeah, I never did either. Now, the caveat to that is that there is a place for eyewear, because there are high light environments on Earth where the amount of sunlight coming into your eye can actually do damage and cause you to go, say, snowblind. So I'll have ski goggles with me when I go skiing. I would take sunglasses or something if I was going high altitude mountaineering. If you're going like fishing, right, and there's tons of light coming off of the water, because the reality is that those of us with pale skin, our ancestors lived in a place where the sun was never really that bright. And there is a reality to photoaging. There is a reality to, and I don't know what the ocular complications are. I don't know that anyone's really studied it. As far as like being a white person in a tropical environment. The eye is fascinating though, because it's such a vital organ that the body really works hard to keep it working. I have seen I can't think of, I probably could come up with like 5 or 6 people that I can think of who were truly blind when they died. Not to say that lots of people don't have problems with their vision. They do. And you're going to see more of that in a world of artificial light and screens and people who don't understand these connections between light and their ocular health. But yeah, the eye is incredibly robust. Organ. Yeah.
Great. Let's give Dr. Stillman a round of applause. Thank you so much.